give you a brief message so that we can understand in very easy manner. So, uh, as this name suggests that this disease is related to liver, and we know that liver is the second largest organ in the human body, weighing around 1.5 kilograms, with having a component of fat around 5% in it. Location, we know that it is there in the right upper quadrant of the stomach in the abdominal cavity, and it is pinkish in brown in color and having soft consistency. Why I'm saying this consistency? Because in my subsequent slides and on during this talk, I'll be talking about cirrhosis, fibrosis, or these terminologies, which is important because once liver loses its consistency, which is soft, it becomes fibrotic scarring and eventually will lead to cirrhosis. And this organ is highly vascular. So when I mean highly vascular, that it has got a lot of blood vessels in it, which provides blood as well as nutrition to liver and from here to other organs. So there is no single function which is specific for liver, but liver plays a very important role in not just detoxification but also in metabolic and the secretory function. So mainly it provides nutrient and basically processing of nutrients. And when we talk about blood composition, it regulates it. It produces bile and it produces protein and cholesterol. More than 500 metabolic functions that are known to be handled by liver. Also breakdowns in certain patients who are taking this alcohol and other medication. So detoxification and metabolism of breakdown of medication also takes place in liver only. Then detoxification, as I already discussed, also it destroys basically the dead RBCs or the old RBCs. So about this metabolic dysfunction associated fatty liver disease is a condition which in which the component of fat becomes more than 5% of the weight of the liver, not caused by alcohol use. So whenever we are discussing about metabolic liver disease or metabolic dysfunction associated fatty liver disease, there will be no intake of alcohol. Alcohol could be a contributory factor. When we talk about this MASLD or MASH, there will be only fat deposition in the liver, which is more than the normal limit. So if a liver contains the fat component, which is more than 5%, then there are chances that it will become fatty liver disease. And if left untreated, it can progress to MASH also, where along with inflammation, there will be ballooning as well as steatohepatitis. So being overweight or obese, having type 2 diabetes mellitus, dyslipidemic condition, dyslipidemia is high cholesterol, are all those comorbid condition which is associated with and has an increased risk of metabolic associated steatotic liver dysfunction or liver disease. So there are some predisposing condition as I already mentioned, but apart from this, if the patient is having high BMI, that means if the patient is obese, then there are chances of landing up into MASLD. So prevalence, you will be surprised to know that 1 out of 4 people have MSLD regardless of the weight. So it is not that those who are having obesity or those who are having high BMI with metabolic comorbidities are only one who can get this disease. But yes, there is a condition called lean fat also. So if the patient is not having excessive weight or is not obesity or more morbid obesity, he can also have MSLD. So uh, that out of 10, 6 diabetics and 9 patients with severe obese can have MSLD condition. So it is very important and it is very important. So if and I would like to also tell one thing that this is not a disease of adult. Every age group, there is a male predominance for this disease, but female is also affected, and in fact, children are also affected with this disease. So regardless, as a risk factor of progression to MASH and fibrosis, there is basically when we talk about fibrosis, scarring, cirrhosis, hepatocellular carcinoma, nodularity, and other things, there is this progression. So not a single day or not over a period of 3 or 6 months you will become cirrhotic or fibrotic. So it takes a time. So when your liver is healthy, that means the fat component in the liver and the fat content in your liver is less than 5% or at 5%. Your liver is healthy, but when there is fatty liver accumulation or the fat accumulation over your liver, the deposits of the fat cause liver enlargement, and that there will be capsular bulging. So eventually, if the deposition is high and there is no stoppage of this deposition, it will eventually lead to scarring and fibrosis. And once liver reaches the stage of fibrosis, then there are chances of reversibility. But once it goes into the form of cirrhotic, then it is irreversible change, and you cannot reverse this condition. So basically, here when I talk about this progression, there is a demand and supply kind of a thing. So if there is a high supply of fat into your body, it will start getting accumulated in your liver and around your liver. And if the demand is less, so fat you are supplying to your body in high content, but there is no demand from the body. Uh, when I say demand, that is physical inactivity. So your work is like that. You're not doing any exertion activity. You're not doing exercise. You're not uh, having yoga. So all these things will not have a burn of fat from your body, but excessive consumption of fat can lead to this deposition and eventually progression to fibrosis and cirrhosis. So there are certain difference between MSLD and MASH. So in basically when we talk about this steatosis is accumulation of fat around your liver and in your liver. And when we talk about this MASH is basically along with fat accumulation, there will be inflammation and scarring also. So fat accumulation in liver is also known as steatosis, and steatosis will lead to inflammation of hepatic cell, which is the liver cell, and is known as metabolic dysfunction associated steatohepatitis, that is MASH. And scarring of liver on benign stage is also known as fibrosis. So once there will be deposition, followed by inflammation, and followed by this fibrosis. Then, apart from these, basically comorbid condition which can lead to MASLD, as I already told you that obesity is one of them. Then metabolic syndrome like dyslipidemia, diabetes mellitus, hypothyroidism, a patient taking prolonged therapy of steroids. All these can lead impairment of liver dysfunction and deposition of fat. And there are certain medication which if we are using and we are using for very long time can also make a patient go into that liver fatty liver disease. And most important, this physical inactivity. So as I already discussed, this demand and change supply. So if your body is not demanding, but you are supplying fat in high content and you're not doing any activity, that can also lead to this condition. Excessive intake of junk and processed food, packed food can also lead to this condition. Then certain patients are also there who says that doctor, I don't eat too much outside. I do my activities also. I don't have any metabolic condition. I'm not obese. Then why I get this condition? Then there are certain genetic dispositions also, the hereditary conditions are also there, which make you prone for this disease and eventually lead fatty liver disease. Uh, being overweight or obese causes fat to accumulate in liver. Obesity increases the amount of fat which constitute more than 5 to 10%, will lead to MASH and scarring of the liver. There is an interconnection between this metabolic dysfunction associated fatty liver disease and diabetes mellitus. And basically, they are bidirectional. So, if the patient is having diabetes, then there are chances of getting metabolic MASLD is high. And when patient is having this metabolic liver disease, then there are chances of high prevalence of diabetes in those patients. And to the tune of 2 to 4 fold increased risk of developing diabetes in later life. Most importantly, we need to understand what are the symptoms of this fatty liver disease. So, supposedly, if you are going for ultrasound abdomen and you get this fatty liver grade 1 or grade 2 in your stomach and you don't have any symptoms, your liver functions are also fine, then you no need to worry. But just confirm with your gastroenterologist or your physician whether there are chances of you being getting this disease in later life or not there. But if you have symptoms along with these finding in your ultrasound or liver function test, then you'll be in soup and you need to uh, uh, high up your antennas and get yourself tested further so that we can detect whether you are suffering from MSLD or not. So abdominal pain, which is predominant in the right upper quadrant, there will be weight loss, and at times patient have nausea, vomiting, loss of appetite. There will be redness of your palm, which is known as palmar erythema, extreme of fatigue. Patient can have jaundice, uh, but very small proportion of patients develop this jaundice. But yes, jaundice is also a feature. Then, if you see in ultrasound, there are chances of portal hypertension if the patient has become cirrhotic. It could be enlarged spleen, portal vein diameter will be high, and there are certain cutaneous features which can also be seen in patients who are cirrhotic and having chronic liver disease because of MASLD. Then, enlarged blood vessels or superficial blood vessels, we call it spider nevi, angioedema, which can be seen on your cutaneous skin, through which we can think that this could be a patient of chronic liver disease secondary to MSLD or MASH. And eventually, if the patient is in chronic liver disease state (CLD) and the patient is cirrhotic, then whether he or she has decompensated or not, patient can have confusion and trouble in concentration also because of impaired detoxification of metabolites that gets accumulate in liver and causes this type of symptoms. So, after discussing about the pathogenesis, what basically leads to MSLD, then what are the symptoms? Now we move on to management part. And management, first we need to diagnose this condition, and accordingly, if the patient is having proven MSLD or MASH, then we can how we can treat the patient. So fatty liver can be a silent killer because the progression of disease is very gradual and very slow. The diagnosis of metabolic liver disease often involves the following. There are certain blood tests through which we can screen the patient. Then we have this imaging ultrasound or fibroscan equipment through which we can detect the fat component as well as the fibrotic component. Then the gold standard, which is that liver biopsy. Basically, it is very important for MASH patient to detect whether the patient is having steatohepatitis or not. And not just this metabolic associated dysfunction of fatty liver disease, but there are certain other diseases which are overlapping, can be detected through liver biopsy. Then we, for better delineation, we have the CT and MRI imaging technique, which can help in diagnosis the patient of MASH or MSID. So most common blood tests are SGOT and SGPT, basically transaminases, which we can do through a simple liver function test. And find it persistently elevated alkaline liver transferase can be associated with this severe disease progression. So not in all cases, because up to 80% of patients of MSLD can have normal ALT values also. So no designated ALT cutoff for prediction of MASH or advanced fibrosis in MSLD patients. So I'm not saying that a simple liver function test can detect your MSLD or MASH condition, because in 80% of the time your liver function will be normal. So it is the basically the combination of symptoms, the blood test and the imaging technique which can tell us whether you are having this MSLD or MASH or not. There are certain other parameters which we can measure through blood test and your demographic scores. Uh, we have this FIB4 score, NFS, NFLD, basically fibrosis score, which contains age, AST value, ALT value, platelet values. And in NFS, we have age, AST, ALT, platelet count, your BMI score, fasting blood glucose levels, and albumin also. So these scoring methods have been established to diagnose more better than ALT-AST alone. And online tools are also available to calculate these scores. You can enter values from your blood reports and generate the score to understand whether you are at a risk of developing MSLD or MASH in later life or not. So when we talk about diagnosis, we have a certain non-invasive test, predominantly with ultrasound and fibroscan. Then we have invasive tests, invasive like liver biopsy. So ultrasound very easily available, economical also, and a reason for most of the accidental diagnosis of this fat MASLD. Uh, and only detects MFLD, that is fat component of more than 25%, and basically differentiate between fat and fibrosis. So, if we get this rough idea that the patient is having high content of fat, then we need to check with the fibroscan whether the fat content or the fibrosis is there or not. Because through ultrasound, we cannot differentiate between fat and fibrosis. Then another non-invasive test, which is transient elastography, it can diagnose MSLD with a fat content of more than 10%, and it is very useful in differentiating between fibrosis and fat content. and very easy to operate to need a training to detect and to do this procedure. But there is one thing, because misinterpretation in obese patient is there, because that probe cannot reach the site from where we detect this cap and LSM value, basically the fibrosis and the fat component value. So it is basically need a proper training to learn about this technique and to do and implement on the patient. It works on the principle of transient elastography. We get basically two values from this. One is LSM value, which is liver stiffness measurement, and second is CAP value, that is control attenuation parameter, which basically tells about the fibrosis in the liver and the fat component in the liver. Then we have this non-invasive technique, that is MRI, uh, gold standard to detect fat content, but it can measure fat only content more than 1%, so more, better than fibroscan. Widely used technique for liver donor patients. Before we are donating our liver to a patient who are suffering from liver disease, basically the surgeon checks for the fat component and other through volumetry, whether the donator who is donating the liver is healthy or not. Uh, but the thing is, there are few disadvantages with this test. Basically, the cost, and it is not widely available. Then we have this invasive technique, that is liver biopsy, which is also gold standard for diagnostic MASLD, and only method to diagnose metabolic dysfunction associated steatohepatitis. Uh, if we are doing a biopsy for a patient who we are suspecting that the patient is having MSLD, but then there are certain conditions who can have this overlapping features, and if the patient is not having this MSLD, then there are chances that in future he can develop this MSLD or MASH. So through this liver biopsy, we can also check for whether the patient can have this disease in future or not, if something is there in initial investigation. Also, it is painful uh, and individual dependent, and the chances of misdiagnosis in early stages of MSLD is also there. So how this basically progresses? We have discussed that not overnight this fatty liver disease will become MSLD or MASH, but it takes its time and the progression is very gradual. Almost 70 to 75% of the patient who have this isolated fatty liver disease requires none or very minimal progression to fibrosis, and there are no risk of death compared with the general population. But if the patient is having a mild inflammation or fatty liver, there are chances of having variability with some risk of progression. And once the patient is developed MASH, which is that 20 to 25% of total MSLD patient, then there are chances of going into cirrhosis and eventually into hepatocellular carcinoma and decompensation. So a MASH patient with cirrhosis takes almost 6.5 years, and there are chances of almost in 7.2% patient over a period of 6.5 years that they can develop hepatocellular carcinoma. And decompensation, when I say decompensation, that means either they have developed ascites, that is accumulation of fluid because of portal hypertension in their abdominal cavity, or bleeding through varices, or encephalopathy because of ammonia accumulation, and when liver is not able to detoxify it. So, over a period of 7 to 10 years, 90 to 45% patient is a very big number, can go into decompensation also. So, one thing is very important to note, that the patient of cirrhosis or this metabolic liver disease have a higher rate of risk of death because of cardiovascular manifestation and not because of liver per se. There are chances of malignancy, and fibrosis progression is associated with diabetes mellitus, weight gain of more than 5 kg, rising ASLT and ALT levels also. So progression is gradual, but we need to check, and we have to put patient on surveillance who are having a high risk of developing MASH and fibrosis and eventually cirrhosis over a period of time. So it is very important to act before it is too late. Uh, the progression of MASH can also increase the risk of heart-related diseases. As I already mentioned, that the patient who are having this liver-related cirrhosis and fibrosis and MSLD dies because of cardiovascular manifestation and not because of liver in first go. So metabolic dysfunction associated with steatohepatitis is more serious form of MSLD, in which you have scarring of the liver, MASH can lead to cirrhosis and liver cancer also. So how we can treat patients? So we have this lifestyle modification, which we call it as a non-pharmacological therapy. Then we have this pharmacological therapy. So diet is very important. As I already mentioned, lot of water, a balanced diet, avoid junk food, avoid processed and packed food, regular exercise. Almost 45 minutes of regular exercise is very important. Lifestyle modification. If you're taking alcohol, you are consuming tobacco, you're having this smoking. So you need to stop all this with immediate effect if you're seeing sign of MSLD in your initial screening test. Then there are some medications also which can lead to this condition. But yes, now we have a lot of new drugs are coming which can treat this condition if your patient has not gone into cirrhosis. Control your weight. So in when I say about lifestyle modification in MSLD, I mean to say a weight loss of almost 7 to 10% to reverse this condition histopathologically as well as symptomatologically. So combination of hypercaloric diet and moderate intensity exercise provide best likelihood of sustained weight loss. Weight loss of at least 3 to 5% of the body weight helps to improve steatosis, that is the fat content and the that fat accumulation, and loss of weight of 7 to 10% to improve the majority of histopathological features of MASH, including fibrosis. So, till the stage of fibrosis, there are chances that we can reverse the histopathological features, we can reverse the patient condition. But once the patient is landed up from fibrosis to cirrhosis, then it is irreversible. So weight loss effect on MSLD, supposedly if you are having only steatosis, that is only fatty liver, then a loss of more than equal to 3% of weight is very much adequate. If your liver has developed inflammation and ballooning of hepatocyte, that is liver cell, then we need to have a weight loss of more than equal to 5%. Also, if the patient has developed this NASH, then the resolution is seen in only 64 to 90% of patients with a weight loss of more than equal to 7%. And if you have developed fibrosis, then the reversal is only 45% with the weight loss of more than equal to 10%. So at each step of this liver inflammation and liver steatosis, the lifestyle modification is, we plan basically lifestyle modification accordingly. Diet, very important. As I already discussed, you need to cut down on junk food. You need to cut down on carbs. You need to cut down on alcohol, smoke, tobacco. You need to take a balanced diet, mainly composed of vegetables and fruits, olive oil, nuts, legumes, seeds, herbs, and spices, and with moderate portion of poultry, egg, cheese, and yogurts also that you can take weekly. And you should can also take, but not very often, this weak fish and seafood also. So a balanced diet along with regular exercise and physical activity is the foremost important for dealing with this MSLD condition. There are certain exercises like aerobic exercises and resistance exercises. Both have got a different role to play if we are dealing with MSLD condition. So aerobic exercises basically reduces your liver fat, maintains a healthy weight, improves your cardiovascular functioning. Resistance exercises basically reduce your liver inflammation, improve glucose absorption and insulin sensitivity. So and there will be less chances of diabetes mellitus. Also, it improves metabolic parameters with less energy consumption. So, fatty liver, there will be improvement with these type of exercise even at the initial stage, and can have this normal liver also. So how to tackle? Basically, we have this lifestyle tips to tackle with MSLD and MASH. Get enough sleep. So adequate sleep is very important. Exercise, which is not that if you have one day you wake up and you start doing exercise and yoga. No, you should implement it regularly and make it as a habit that you do this exercise of 45 minutes to 60 minutes daily, and burn adequate calories and take less calories. You should be in negative balance when you go for this treatment for this condition. Get enough vitamin and minerals, have regular medical checkups, eat small and frequent meals, and lower your sugar intake along with other carbs. Then we have this pharmacological approach, which Indian National Association for Study of Liver Disease also recommends. Uh, we have molecules like pioglitazone, saroglitazar, vitamin E, Basically, what they do, they have this antioxidant property through which these can help patient with metabolic liver disease or the MASH. So NASH with or without fibrosis in both diabetic and non-diabetic patients, we can use this pioglitazone, and the suggested duration is minimum 2 years. And during this time, we should monitor the patient along with other parameters whether there is improvement or not. Then we have saroglitazar. It is indicated both in NASH without fibrosis, both in diabetic and non-diabetic patients. But this vitamin E is only indicated in non-diabetic adults and in pediatric patients also. So duration of saroglitazar is 6 months to 1 year, and vitamin E is 2 years. So tips: limit intake of saturated fats and trans fats, eat a balanced diet, limit consumption of refined carbohydrates, maintain a healthy weight, quit smoking if you are doing, stop at taking alcohol and tobacco, regular and religious exercises, limit alcohol, avoid, and take medication as prescribed. But the most important is reduction in weight. And if you are having comorbid conditions like thyroid, diabetes mellitus, hypertension, dyslipidemia, you need to take regular medicine and control these diseases also, so that eventually their effect on liver will be less and the liver will not be at stress. So thank you so much for your patience here.
So much, sir, for wonderful talk. This has enlightened us. Now, sir, we will take questions from audiences with your permission.
Yes, please.
Sir, it's matched age-specific disease.
Sorry.
Can we say MASH is a age-specific disease?
MASH is not a age-specific disease. As I already told you, this is not limited to adults only, and this is not limited to obese patient only. So this can affect any age group, whether it is a kid or adult. Adult means male or female both. So this is not an age-specific disease. But yes, uh, if we detect this disease early, then there are chances we can reverse this disease.
What are the common symptoms observed in MASLD patients?
Most of the time, if the patient is having this MEPL and if they are obese, so they will tell that they have this discomfort in the right upper quadrant. Most of the time, they feel lethargic, they feel malaise, they're not able to perform their activity properly, loss of appetite, they don't feel like eating. There will be weight loss also if they are not eating properly. And most importantly, in patients of MAPLD and MASH, if the patient has not progressed to fibrosis and cirrhosis, then there are chances of this cutaneous and other markers will be less. But most of the time, patient can have this vague symptoms of malaise, lethargy, loss of appetite, loss of weight, and generalized weakness.
Which type of food to avoid in MASLD patient?
So, carbohydrates, basically trans fat and saturated fat, you need to avoid. And if you are addicted to alcohol, smoke, then you need to stop all those things.
So what
When I say basically trans and saturated food, you need like white flour. You cannot take the white flour, excessive butter, ghee, all those things you need to cut down on those.
what kind of exercise will you recommend for MSLD patients?
Any exercise, whether it is aerobic exercise or resistance exercise or a cardio exercise, he or she can do any exercise, but at least for 45 minutes. And we always say to our patient that you do such exercise so that your heart rate increases to almost 15 to 20%. So supposedly if your heart rate or the pulse rate of your body is around 70 or 80, so do exercise which can increase your heart rate so that the burn of calories will be more, and the fat which we want to lose from the body will be more.
Correct. Now, on behalf of NASH 24 by 7, I extend my sincere thanks to Dr. Ashok for his enlightening and engaging talk on MASLD. Sir's insights have highlighted the need for increasing awareness about fatty liver disease. I also want to express my appreciation to our audience for their active participation. Stay connected with NASH 24 by 7 on Facebook page for upcoming updates and events. Take care, stay well. Thank you so much, sir, for joining us today.
Thank you.
Thank you.